right. So Dr. Kenrick Ware is a clinical pharmacist and educator specializing in HIV care with extensive experience addressing stigma and disparities in healthcare. As former chair of the Joseph H. Neal Health Collaborative and former chair of the South Carolina HIV/AIDS Council, Dr. Ware has led community-based efforts to combat stigma and expand access to HIV prevention and treatment. His leadership roles within these organizations reflect his commitment to advancing HIV education and equity. Dr. Ware brings his expertise in pharmacy education and HIV advocacy to highlight strategies for reducing stigma and improving outcomes in priority populations. So I want to thank Dr. Ware for being here. I want to thank our HIV task force as well. And I want to thank Dr. Ayana McIntosh for her work in helping to coordinate tonight's event.
Wonderful. Thank you all so much for having me tonight. I'm definitely thrilled and honored to be here. I'm grateful for the invitation. And as World AIDS Day, as the prompt was lifted about what does it mean to us, and I think it's really a sign of perseverance and just diligence over the years with all the strides that have been made in progressing treatment and considerations around people living with HIV and people affected by HIV. I think this is just, as again, although different people throughout the country or the world may not see it the same way, I think this is such a momentous day. And I think about the multiple World AIDS Day that I've had the opportunity to be a part of, and I'm just really fortunate to be here to spend some time in such a great day here with you all. And so we'll talk a little bit about safe spaces, pharmacist-led, HIV stigma reduction, and that kind of that intersection when we think about harm reduction, right? And so I've been really fortunate to not only work with HIV care organizations, but also in the harm reduction space as well. So I'm looking forward to kind of trying to pull those two worlds together and intersect them, because there's a lot of overlap there. This was the pre-session surveys. So again, that's what stated a little bit ago. If you haven't had a chance to complete it, please do. We'll look to address those key points. So some of our guiding considerations: explaining evidence-based stigma reduction strategies, particularly at the level of the pharmacy, and as you'll see more so in community pharmacy practice. Another thing that wasn't mentioned in the bio is that I also have employment in a community pharmacy setting. I've been there a little over a decade, and so that will inform a lot of my conversations here around what we can do differently or perhaps improve upon at the community pharmacy level. And so obviously we think about in the clinic space when we think about harm reduction and stigma reduction, but even in community pharmacy practice as well. So we'll talk about that. Again, the second half of the discussion, we'll really look at harm reduction models, really a model that I've been actively involved with here in my time here in Atlanta, Georgia, in partnership with Mercer University College of Pharmacy. So I'm really drawing on some areas of involvement from South Carolina and now here in the Atlanta area, and actionable steps like what we can do to kind of help with this harm reduction consideration. So I don't have anything to disclose. It was mentioned that ViiV Healthcare is supporting this session, so thank you to ViiV and everyone here for being here. I recognize that there are a host of events taking place on World AIDS Day, so I definitely don't count it robbery that you're here with us and that you're engaging in this session. So core principles of HIV stigma reduction. Some of the things that when we think about stigma reduction, really it can be categorized in a few different ways, but ultimately we want to empower people. We want to really leverage individual strength. Obviously, as we all know, in the spirit of World AIDS Day, HIV is not a death sentence. People are living longer, thriving with HIV. We're thankful that we have advancements such as undetectable equals untransmittable, where if you're not familiar with that concept, in essence basically says that we've reached a point in the HIV care continuum where we can manage HIV in a way that the HIV viral load would be so low in the body that effectively there's no risk to transmit it to other people. So that's a huge development. So when we think about empowerment, that's really at the top. So you might have heard of U equals U, right? So that's what that amounts to. And also that really is a form of prevention, right? You may be familiar with the nomenclature of treatment as prevention. Well, that really harkens upon this reality, right? Is that if we can get the viral load to suppression levels or as low as possible in the body when it's not passed on to others, then ultimately we're preventing transmission from going forward. So that is a form of prevention in and of itself. So that's really empowerment uh, in the highest sense when we start thinking about people living with HIV. Obviously, choice, the ability to decide. When we think of choice from a treatment or prevention standpoint, we're fortunate that we have more and more options coming out for HIV prevention, right? So again, we won't delve into the nuances of all the different medication therapies, but we have oral options, we have injectable options. And so when we think about choice and people's ability to decide, right, it's good to have options, and it's good for people to be able to have a say in what goes in their bodies, right? And so people can have autonomy over what they're actually placing in their body. So that's that's really really empowering as well. Collaboration, working together. Obviously, World AIDS Day and in general in this space is a really good example of how people come together, support one another, provide different resources, collaborate in the community, minimizing harm. So that's an interesting one because we're not just talking about harm from medications or side effects, but harm from people, harm from processes or policies, right? So making sure that some of the even harm from language, right? So you'll hear me try to model that throughout this conversation, discussing more in the people first language and really trying to lead with people as opposed to a diagnosis. And so recognize harm can take on different complexions. And so hopefully, right, that's one of the things that we're mindful of. It's not just contextualizing safety and harm to a medication regimen or to a therapeutic regimen, but also to behaviors and to policies and to other things that can cause people harm, probably at a deeper level than a side effect from a medication. Trustworthiness, right? So honest interactions, being honest about the challenges, right, of living with HIV, right, and making sure that people, even though we have arrived at undetectable, untransmittable, that still requires diligent attention to make sure that people have consistent access to their antiretrovirals, make sure that there's no treatment interruptions. So having those conversations really is not a cure, right? We're hopeful that at some point a cure will emerge, but we recognize that people remain undetectable because they remain consistent and remain diligent with their therapies. And so making sure that people are understanding of that and being honest about the fact that that is what it takes to continue to move forward. So looking at safe spaces, HIV prep, some of those interactions, affirming interactions. When we say affirming, really kind of thinking about making sure people are comfortable with the decision to start on prep, and sometimes with the decision to discontinue prep. So we recognize that prep is one of those considerations that we want people to be on it as much as they feel they can benefit from it. But there may be a time in people's lives where they come to the point where they want to take a break or to not continue on prep at that season of their lives. And so that's something that I think we should affirm and make sure people recognize that it's a way to do it and make sure that we're there to kind of help navigate that. Customizable solutions, right? So that really speaks back to the whole, particularly on the prep umbrella around having multiple options for people to use. Again, multiple oral options, multiple injectable options. We recognize that just because they're available, as we all know, doesn't necessarily always equate to accessibility. And so that's more work that we need to be doing and continue to do to make sure that these options are not just accessible to some and not others, right? But that people can benefit from these customizable solutions, irrespective of their socioeconomic status or where they may be in life. And individual well-being, just overall, how do we encourage people and how do we continue to support people beyond what they're taking, beyond what therapy they're on, but just as people. So considerations that we often see when we're looking at HIV PrEP functioning as safe, HIV stigma reduction. As I state here on the slide, when we think about the evolution of PrEP, recently this past summer we've had a newer injectable option to come out that will last even longer in the body, but we recognize that people still may be most likely to be on oral therapies. There are a few reasons for that, whether that's access. Some of the places where people live may not have the injectable options available, and so oral options may be the the way to go in those situations until the injectable becomes more mainstream. What we recognize in those cases, that's unfortunately an opportunity for partner discovery, particularly if the individual isn't interested in the partner, knowing that they're on PrEP, particularly in some of the cases of intimate partner violence, right? So how could how could that impact that dynamic where someone is taking an oral option and that's uncovered by a partner in the setting of intimate partner violence? Obviously, that would pose safety concerns. In addition to those safety concerns, which we recognize would be paramount, naturally it would probably deter the person from continuing to be persistent with PrEP, right? Maybe lead to decreased adherence rates. Unfortunately, in some cases, it may lead to seroconversion, which is another way of saying people who were not living with HIV have come to live with HIV now. So definitely some concerns around that. So whether or not injectable PrEPs could help with that, right, to kind of help with safeguard some of that, some of those concerns. Naturally, the injectable PrEP side of things, people would need to have reliable means of transportation to go into the clinic to be able to receive these options. As of now, there's some data and some studies going on that to look at self injection, but right now people need to go into the healthcare system to have these products administered. And so while that may circumvent some of the challenges with the oral options, it also brings up other concerns about having, again, that consistent access to to be able to go in to a clinic or to some healthcare facility to receive an injection. So lack of safety like we've been talking about, is really can impede care at prescribing, both prescribing and dispensing PrEP. So think about intimate partner violence. Again, it can equate to decreases in returns for follow-up care, what we spoken a little bit about. So obviously, in those cases, again, a person is a higher risk of that seroconversion that we just discussed. Perhaps that's attributed to the fact that people will uncover, or partners may uncover, that the person is taking the PrEP, particularly the oral option, or even and not to indirectly disparage the oral option. Even going into a facility every 2 months or every 6 months may cause some concern about why is a person going in so frequently to have whatever is being done. So that could also cause some concerns, particularly in some of these unsafer spaces. Talked about the higher possibility of the seroconversion, and if people are unaware of that seroconversion, or again, going from not living with HIV to living with HIV, if they're unaware of it because they're not able to come in to to a facility to be monitored, to be HIV tested, then the transmission can continue, right? And ultimately we can see some concerns with some of our regimens not working the way that they should. One of the things I've been fortunate to work alongside during my time with different community-based organizations is the mobile units, right? Helping, how do we get mobile units out and uh, keep them viable? I recall many World AIDS Day ago where we had mobile units at this particular clinic that would really circulate throughout the state to make sure people had the care that they need in more of a safer space. Right. So that's something when we think about mobile units, it's not necessarily just delivering a service, but it's also creating space for people to be able to come to a mobile unit and engage in care in the best way that they can. Right. So routine testing, routine HIV testing associated with PrEP therapy is paramount, ensuring that people are still not living with HIV. So in the event that people are unable to make it into the healthcare system to have that routine follow-up, it's important to have these mobile units or some touch point where people can go and to get their needs met there. Sexual holistic overall health. So there are other things, obviously, when we think about mobile units, other considerations that could take place there. We're talking a lot, obviously, about PrEP and HIV prevention, but we recognize that even some of your other sexually transmitted infections like gonorrhea, and chlamydia, and syphilis, all those things will be of concern as well. And so making sure that we're in a position to not only test for those, but in some cases treat or even prevent some of those things from occurring. So mobile units can be repurposed and continue to evolve to provide that care, that comprehensive care that people may ordinarily miss out on in the absence of them. So now I want to kind of go through a few scenarios looking at uh, customer interaction. So again, I stated at the outset, I really wanted to kind of ground some of this conversation in community pharmacy settings and some of the interactions that may take place between a customer and a pharmacist and or a pharmacy technician. I think while I'm here, I want to pause on that a little bit. I think we talk quite a bit about pharmacists, but not as much about pharmacy technicians and the role that pharmacy technicians will have in people coming to the pharmacy and the interactions that we have with people coming to the pharmacy. So even though these settings highlight pharmacists, I definitely want to underscore the fact that if you spent more than 5 minutes in a community pharmacy, you recognize that pharmacy technicians have a huge role in the operations of a community pharmacy. And so I definitely want to center them in this conversation as well. So a customer presents to a community pharmacy with a prescription for PrEP. The customer mentions that she is experiencing intimate partner violence and would like to have the prescription filled as soon as possible. The pharmacist states that before she can fill the prescription, that she needs to have a conversation with the customer about the extent of the partner violence being experienced. The customer angrily states, "I have told this story a million times and I would not tell it again." So how should the pharmacist respond? So we'll get into some potential options, but obviously there are a few concerns here, right? Obviously, when we think about pharmacists looking to dig a little bit deeper into whatever situation a customer presents with, we obviously want to keep in mind every pharmacy is going to be constructed a bit differently. So, what are some of the safety parameters there around privacy? Where was this conversation taking place? I can't tell you how many times I've overheard, whether it's a pharmacy technician, a cashier, or different people really being a bit reckless with some of the health information and some of the things that people are experiencing. So this could have prompted some of those some of this reaction. Obviously, the person had told this story several times before. So naturally, when we think about intimate partner violence or any type of violence, there's a level of re-traumatization that happens each time the story is being told. So what could the pharmacist do in this case? Again, if you have some suggestions as well, please feel free to place those in the chat. But obviously, one thing comes to mind. We think about affirming that guarded response, right? Making sure that people feel affirmed that, hey, I recognize that this is a sensitive area. And the request for IPV or intimate partner violence details can be directed to maybe the healthcare provider, right? So is it really necessary, particularly at that point in time, to ask a person to disclose all this information prior to dispensing a medication, right? Obviously, this could be viewed as gatekeeping and kind of this a way of making sure, so to speak, that someone should benefit or should be on this therapy. So that could be a concern. And explain the next steps. Like, so after you receive that information, and again, hopefully the person is comfortable enough to share to whatever degree, that really have some conversation around the next step. So it's important to validate the customer's response, right? That how it can feel intrusive or it may be intrusive. Explain that the healthcare provider can update the pharmacist, right? So in some of these cases, and if we're being honest, a lot of this is pharmacists or pharmacy personnel really their own curiosity, right? They're really trying to satisfy maybe some suspicions that they have, which really run counter to actually doing what's best for the customer at that point in time. And then based upon the information provided by the healthcare provider, then the pharmacist can kind of re-engage about what other things that may be helpful, whether that's for filling the HIV prep, obviously pending the availability, and even sexually transmitted infections that may also accompany that prescription for prep. So some other considerations, I mentioned a few already, right? We start thinking about the pharmacy setting and the layout. So where is this conversation taking place? Right. As I stated here, the privacy areas, depending upon what they're being utilized for, whether it's immunizations and other considerations there, then it may be a concern with disclosing that information. The intimate partner violence perpetrator may come to the pharmacy with the customer, so that unfortunately can happen where the person is not at liberty to speak freely because the person is alongside that individual. So I want to make sure that we recognize the challenge that would present with being as forthcoming. And also, this is an opportunity to really kind of talk about some of the over-the-counter products that are available. And again, this will need to be done in a way that is affirming of sexual health, not in a judgmental way, but maybe kind of having some of those conversations about some other options that are there at the level of the pharmacy. Our second scenario, so customer dropping off a PrEP prescription weeks after it was written. So a customer presents to a community pharmacy with a prescription for PrEP. The pharmacist reviews the prescription and confirms that the medication is in stock. So if you work in community pharmacy, that's or any type of pharmacy, that's the first hurdle is do we have it or not? And it looks like it's there. The customer mentions that he is currently in a relationship and where he is trying to survive intimate partner violence and that he views PrEP as a means for him to protect himself. The pharmacist now noticed the prescription for PrEP was written 3 weeks ago. When the pharmacist brings this to the customer's attention, the customer states that due to his transportation issues, he's unable to get to the pharmacy until today. So what should the pharmacist do next? So obviously one of the glaring concerns here is that when the prescription was written a few weeks ago, perhaps since that time, the person may have encountered HIV, some seroconversion may have taken place. And so that could be a challenge, obviously, with filling the PrEP prescription because, again, it's been a substantial amount of time that has passed. Now, each pharmacist or each healthcare setting will obviously do their own due diligence to determine what that threshold is. What do they need to do to make sure that the person is still not living with HIV? So here are some suggestions to where people can start. So expressing gratitude that the customer is deciding to initiate PrEP, right? So again, that affirming and safe response. So that person is taking a huge step forward, particularly in light of some of the concerns that were raised. Also, just letting, being as straightforward as possible. Again, going back to that honesty that we talked about, because a few weeks has passed, right? There are some concerns as far as HIV transmission. And if they're not in a position, they're at the pharmacy to conduct an HIV test, perhaps looking to see if there's somewhere in that local vicinity that would be in a position to test, right? Because we want to again make sure that the person is not living with HIV. So I think that's the biggest consideration here. Again, naturally, there are some states throughout the country where pharmacists are initiating PrEP, so they may have greater capacity to perhaps test there and prescribe, and other places throughout the country. So I recognize this isn't a one size fit all approach, but in some cases where I practice frequently, we don't have the capacity to initiate HIV testing there on site. So what I would hope to do is talk to the customer and kind of have a conversation about perhaps some places that perhaps are close by, and also making the customer aware of the challenge with filling the PrEP with 3 weeks or almost a month from when it was written. You also can contact the healthcare provider to see if there are more updated HIV tests on record, so that could help. But I think the biggest key here is ensuring that people feel heard and seen, and taking the time to explain the reservation that you may have about filling that prescription because of the time that's passed. And again, having the conversation with the customer. There may be a different explanation. Perhaps they provided, an outdated test, some other considerations that may help with informing whether or not you would actually fill the prescription. So in contacting the prescribers, as we talked about, really taking that time to explain the situation, expectation that the customer began prep already. So in some cases, and we typically see this from a medication standpoint as well, non-prep medication standpoint, where people would have a prescription sent in. There's a couple of weeks or so, even so much time has passed sometimes where you return the medication to stock, then you have to reprocess it. Right. So it's not an uncommon occurrence where people will present to the pharmacy sometime later after the prescription has been prescribed. And so contacting the prescriber is paramount because when that prescription was written, it was probably or more than likely the understanding of that prescriber that the person was going to start on it pretty soon. So making the prescriber aware of that and that shared decision making, right? And so that's not necessarily trying to shift the blame or shift the responsibility completely, but just having additional perspective. Like maybe the prescriber can inform you about something as a pharmacist that may help you feel a bit more comfortable with filling the prescription, or maybe it's a situation where they would have to reappear to have HIV testing done. Again, convenience is the key, making sure people aren't, too far out of the way to get additional testing. As was stated in the scenario, the person has struggles getting to the pharmacy because of the transportation concerns. So the last thing you want to do is impose additional undue burden on people, but again, helping people to understand kind of the challenge with filling it. Counsel the customer about ongoing prep stipulations. So that's also important. I think that's one of the things that I feel like we can spend a bit more time on when we're counseling about prep is that ongoing commitment to the laboratory testing, to other considerations that beyond that initial fill, right? To make sure that we do the best we can to help with prep persistence. So if you look into the literature and into the data, we're really having some challenges with keeping people on prep. One, obviously making people aware of it, but definitely keeping them on it. And some of that may be attributed to the fact of really helping with those expectations that this is going to be an ongoing consideration that you will have to continue to be tested and with different types of tests, particularly an HIV test, to make sure you're not living with HIV. And our last scenario we'll talk through here at the community pharmacy level is side effects, right? So obviously, and particularly here, we have perhaps more of the oral option in view. But a customer presents to a community pharmacy with concerns about her PrEP therapy. She reports being adherent, but that she is considering stopping the medication due to nausea that she describes as being unbearable. Also, because she is currently experiencing intimate partner violence in her relationship, she is fearful that her partner will mistake her nausea due to the PrEP therapy. And in parentheses, the partner is unaware of that she's taking it for her being pregnant. So now the customer requests advice from the pharmacist. So how should the pharmacist respond? So hopefully this isn't the same pharmacist responding to all three of these scenarios, right? So that would make for an even longer shift. But what are some things that could take place here? Obviously, again, that starting with that affirmation or acknowledging the difficulty that the customer is facing. And then, most pharmacies, I would presume, have pregnancy tests available. So maybe making a recommendation there to rule that out or in, excuse me, depending upon the person's perspective and how they view pregnancy in that situation. So that may be something, again, the results would be there to really inform that person and explain that there may be options that may circumvent some of the nausea that a person's experiencing. Obviously, if you're in the pharmacy setting, you may be in a position to kind of help with recommending options that are available, perhaps that may kind of help with some of those symptoms that are over the counter. Sometimes they may require a prescription, but again, trying to help to do what you can there in the pharmacy setting. Obviously, it sounds like the partner isn't too enthused about the potential of the person being pregnant, and so hence it would be important to for this individual to know their pregnancy status, just as what's happening in their own bodies. Although the scenario is not disclosed to specific PrEP medication, oral medications can be a bit more likely to cause the GI symptoms. What are non-oral or injectable options? But again, there is she may be living in an environment or in an area where the injectable options aren't available. And that's one thing I've learned over time, is that you definitely don't want to make recommendations to people that aren't as practical to them. So what I mean by that is, to say that, oh, we have an injectable option out that you can take once every 6 months to prevent HIV, and you will be fantastic going forward, and you only have to take it twice a year. But if it hasn't really made it to that particular area, right now we're raising the expectations of people when in fact they may not be able to have access to it where they are. So I think making sure that we do our diligence to make sure that people have access to these products where they are, and the manufacturers are doing a really good job of ensuring that these products are getting to where they need to get. But there may be some places where they just haven't made that trek yet, and so it's really important. Again, I think it's a good rule of thumb to make sure that we're not discussing options that again aren't as pertinent to a person there in that local context, because they just may be out of reach for that person at that time. So it's just kind of reiterating some of the things I just mentioned about tempering those expectations about the alternate PrEP therapies, not just availability, but even insurance consideration. Again, I recognize that the different companies are working really hard and deploying a lot of resources to make sure that these barriers are not insurmountable, but in some cases, uh, people just may have some of these concerns with either covering it, or if the PrEP, injectable PrEP, is actually available in that particular location. Obviously, in most cases, because people will need to have it in a clinic or in a healthcare setting, then we typically wouldn't expect to find it there in the pharmacy. Therefore, that would constitute a person having to make an additional trip to go somewhere else. So being mindful of that. Hence, going back to that collaboration about making sure that we can communicate and collaborate with people in different organizations that are not too far away. And as I alluded to, really making sure that we look through the profile, ruling out other medications that perhaps could be causing some of the GI side effects or additional GI side effects, and maybe offering some options. Maybe sometimes the GI side effects could be alleviated with food, as we know as pharmacists, sometimes not, right? So basically trying some things that could kind of help to provide a level of relief. Now I want to pivot some to harm reduction, specifically as pharmacists as harm reduction champions. As I stated at the outset, it's definitely quite a bit of overlap when we start thinking about the synergy with HIV prevention and harm reduction. So here, what you're looking at is I have a thriving partnership with the Georgia Harm Reduction Coalition, where this organization does a ton of great work. And what you're seeing is a harm reduction vending machine. So if you're not familiar with those, it's in essence what it sounds like. Where as far as the vending machine where we have harm reduction, safer substance use equipment and supplies within the vending machine. So perhaps Narcan is in there, fentanyl test strips, as you're viewing here on the screen. Other considerations there that could kind of help with safer substance use, xylazine test strips. And so we think about fentanyl test strips. Again, if you're not familiar with these, in essence, they're qualitative tests, right? So what that would suggest is that they are testing the substance that people are using. I guess the component of what they're testing. So perhaps not everything that they're using, but what they are actually testing is looking to determine the presence of fentanyl in it. So a key point is it wouldn't necessarily say how much fentanyl is in it. Again, that would be a bit more quantitative. But as you can see from the image, it either the product has the fentanyl in it, which is which is uh, which is pictured by one line, and then it doesn't, which is two lines. This chocolate chip cookie effect is a really important thing, and we spend quite a bit of time educating on this through our collaboration with the Georgia Harm Reduction Coalition. Is that, as you can see, that because we recognize that these substances that people are using obviously haven't been FDA approved, they're using what we would consider maybe illicit substances, that the fentanyl obviously wouldn't be evenly distributed throughout the entire substance. So what that would mean for a community is, and for people that we're discussing this with, is that what they may test, while that may actually show that no fentanyl is in it, that's no guarantee that the rest of what they're going to administer will not have fentanyl in it either. And so kind of helping to help people to understand that component is a really key point. So again, these vending machines, they're located different areas throughout the Georgia Harm Reduction Coalition. Different items available in it, as I spoke to there. The products are free to consumers, and so in essence, people come, they would type their zip code in, and then the thought there is to hopefully try to track some of the data where people are utilizing the products, accessible on a 24-hour basis, and no quantity limit. So the quantity limits is important because we're hearing a bit more anecdotally that people are utilizing the products, and maybe they take multiple of a product to distribute to others, right? So it's not necessarily, again, I can't completely rule out the hoarding effect, but usually it's to kind of help to be what we consider secondary distributors and really getting these products to other people who may not have the same level of access as they do. Because obviously to get to the vending machines, as you can see, it's in a stationary position. So it still would kind of take some type of privilege or access to even be able to get there, right? So there may be cases that perhaps people can get there and perhaps other community members can't. And so they're looking to help in that respect. This is an article that described really this academic partnership, this burgeoning academic partnership that I'm really excited about with the Harm Reduction Coalition and Mercer University. So this is where we kind of described our experiences. It was really written in an academic way to this academic journal to really kind of talk about through the advanced pharmacy practice experience that is offered in collaboration with the harm reduction and other organizations, what students actually were able to get from that experience, kind of highlighting the need for more experiences like this in pharmacy education. These products are pictured there at the distribution center. So in addition to some of the outreach events that we go out into the community and have some of these educational conversations, as I just described about the fentanyl test strips, another cool opportunity with the Georgia Harm Reduction Coalition is working in some of the distribution centers where actually distribute these products throughout the states to areas obviously that are maybe less populated than the Atlanta area. So diffuse it throughout the state. What you're looking at here at the top, it's my left-hand corner, would be safer substance use supplies such as a tourniquet. We have, as you see, some of the cotton swabs there. It's an alcohol container in there as well. So other things in there to kind of help with, again, that administration of the substances. Again, we're talking a harm reduction model. So if people are deciding to use, what can we do to help people to use in a safer and a more responsible way? The second image are a series of crack pipes, right? And so things that people would utilize to, again, to really guard against oral infections. So the thought here is to make sure that people choose to smoke or however they ingest their products is to make sure that obviously if they're doing it orally or through the oral route, that we are giving them unused products to continue to use. And hopefully, obviously, I want to present both sides of it. We do have a connection to care, to the clinic option where people they do arrive at the place where they would like to discuss cessation or stopping, that they can do that as well. The bottom left-hand corner is really as you can see, the naloxone, the intramuscular option. We obviously have the intranasal option as well, but intramuscular. And these are the test strips that I discussed earlier. Whether you see the xylazine test strips, another substance that's been making its way into drug supply. and your fentanyl test strips. So barriers to accessing syringes in community pharmacy settings. All right, so kind of talking a little bit about that as far as what are some of the challenges, whether it's presuming crime rates, stipulations of medical necessity, arbitrary number of syringes dispensed. So we see this quite a bit in pharmacy settings where people will, and for all practical purposes, make up rules about how many they can dispense or they cannot dispense. So these are some of the things that come up when people are making justifications when it's really just discrimination about what they can and cannot sell, whether they are anticipating crime or aggressive behavior from customers, other considerations about dirty syringes being littered throughout a particular area, only for people who really need them. So that's really a more problematic one because who's to determine that? And I actually had a conversation with a pharmacy technician who had spent the last 10 or 15 years at Starbucks for transitioning to working to the pharmacy. So nothing against people who work at Starbucks. And if you enjoy Starbucks, then that's great as well. But my point to that person was that obviously their medical training hadn't really positioned them to say who would really need them, right? Considering their background was somewhat pretty far from the healthcare arena. But people make these judgment calls all the time. And so while they may be experts in lattes, they probably aren't the most informed with who will really need a syringe. Believing that discontinuing use is best for the individuals and society overall. Right. So again, some of these judgments that really impact the care that people receive. So this is what I kind of alluded to about this medical necessity, like what qualifies pharmacy employees. Again, somewhat picking on my colleague there who was a former Starbucks employee, but whatever the case may be, we really don't have uh, good evidence or training to really determine whether or not it is a medical necessity. So when people are making these judgments, right, that really it's really just discrimination. It's veiled discrimination, and sometimes it's not as veiled. It's just overt discrimination based upon what people think people should have access to. So what happens? Obviously, discriminatory transactions. We see that some, right? Obviously, the necessary use you have to be diagnosed with a certain condition for you to be able to get it. Oh, and also another thing here is this covert inventory management, and what that really kind of refers to is that perhaps people not actually stocking or pharmacy managers not stocking certain syringes in the pharmacy so they can tell consumers or customers that they don't have them. When in essence, it was a deliberate decision to not stock those products or only stock the syringes that they see people aren't using as much of, so people would be deterred in that way as well. So some ways as far as pharmacy support, obviously it's going to take a multi-pronged effort when we think about boards of pharmacy, what we do at the pharmacy school level, community pharmacy, state pharmacy organizations. It's really going to take a team to address it. So opportunities for pharmacy settings, obviously the OTC Narcan utilization, right? Recognize that may be a bit costly for some people who are coming into the pharmacy. Another concern with it, obviously, too, is the challenge would be that it's sometimes behind the pharmacy counter, so that's an additional barrier there as well. So that's what I have. I want to leave a little bit of time for any questions or comments. But again, thank you for your time and being here with me today. And I'd love to chat with anybody who has any questions or comments.
I think this was really great. Dr. Ware, you did a great job. Thank you again for participating in World AIDS Day. And I really loved how you tied in the harm reduction as far as the vending machines. Like I thought that was great in talking about fentanyl. How do we shift I guess talking to our patients and reducing that stigma in the community setting with our patients who are living with HIV and who also have substance abuse as well or use substances as well. How do
So
we
go
have
ahead,
a
go ahead.
not Go ahead, I'm sorry.
No, please go. Sorry.
No, I was just gonna say, how do we have that non-stigmatizing conversation with our patients when it comes to that? Because I think about so I have patients who come to get chemotherapy and they may be HIV positive and they also have substance use as well. I currently have a patient that I'm doing that with. So how do I like train not just myself, continue to, educate myself, but also my staff and my students? Like, how do I do that?
So good question. So and thank you for your kind reflection of the presentation. But I think it's really kind of normalized, and I know we say that a lot in this space, but
Hmm.
really kind of having that conversation in conjunction with as a holistic health consideration. So I think sometimes when we talk about substance use and safer substance use, right, we somewhat segregate it, for lack of better words,
Right.
into its own category around, oh, now let's talk about substance use. So let's talk about safer substance use. And oh, have you heard of fentanyl test strip? So I think you would benefit from Narcan. But it's almost like it's a detached conversation, whereas actually really positioning it as, just overall health. Like we want to make sure
Right.
that we're concerned about your health. And so I think having the conversation in the context of everything else that we're discussing is really important. And I know that's going to look different in different settings, but I think far too often, again, we kind of put it in a separate conversation. And so
Right.
I would argue we inadvertently stigmatize it ourselves, right? As healthcare
Right.
professionals, because we create this space where we're discussing it as an afterthought or as a secondary kind of conversation or as a separate conversation. So I think wrapping it into the whole conversation around holistic well-being. These are other tools that we have to make sure that you're healthy and that you're safe. And I think also being honest about the tools as well can help with that conversation. So I mentioned some of the limitations of the fentanyl test strip. So making sure that people understand that we're not just looking to force this upon you. We want you to have agency to determine whether or not this is something that you would benefit from. And again, I
Right.
think that's the beauty of the harm reduction model, right? It doesn't say harm removal, right? But it's just we're looking to do the best we can to help people to reduce harm and empower people to make that decision for themselves when they have all the information. So I think folding it into our general conversation about health and wellness and not making it a separate consideration when again and I'm guilty of it in different respects too. I try to be more mindful of it, but not inadvertently stigmatizing it ourselves by having a separate conversation or having kind of a weird build up to the conversation and this awkward kind of exchange, but bringing it into the main conversation that we're having with the patient. So I know that was a lot. Hopefully it somewhat addressed what you asked, but that's really kind of my take at it.
No, I did. Thank you so much.
No, thanks for asking it.
Thanks, Shantae. We did have a question from Stephanie Hassan in the chat about, are the strips the only option for testing for fentanyl for customers?
So great question. So as far as I would say it depends on what setting you're in. So we think about obviously there may be other options to test for fentanyl that are a bit more analytical that would obviously be in a lab and a different considerations, right? That would be beyond at the community level. But when we're talking about customers, when we're doing community outreach or when we're out in the communities, those are really going to be the most accessible options, right? Because those would be things that, and we're supported or the Harm Reduction Coalition is supported by funding and other streams that are able to provide these strips to people at no charge to them, which is huge, right? Because we really don't want people reusing the strips, right? Really we want them to use one strip per time that they test the substance. So to your question, no, there are other ways, other analytical methods of testing for fentanyl in some of these substances, but in some of these substances that people are using, but the challenge there is they're obviously a bit more costly. Assessing those instruments and other things would probably be out of reach of a lot of people who are living with substance use considerations. And so I would think the more practical option would be the test strips. But yeah, there are other, I guess, more high tech or more analytical ways of doing it. But I'm afraid they're a bit more out of reach of people.
So earlier in the conversation you mentioned that some pharmacists will block access to needles to patients who are looking to purchase needles so that they can use it for substance abuse. Um, so I remember when I was in pharmacy school, this was a hot topic, and it sounds like it's still a hot topic, and it's still a barrier for some pharmacists to overcome, to understand. Uh, Sometimes how you phrase things, how you educate um, providers and pharmacists can make a difference. The question is, are there any articles or surveys out there that shows which approach is better when educating a pharmacist or a pharmacy technician in regards to how this can cause harm and uh, why they should or why they should not be practicing that?
So great question. So now I understand that. So thank you for repeating it. So I think so as far as when we say articles and studies, I mean, there have definitely been some data to show that, and I don't know if this directly gets to what you're asking, but people will present to different pharmacies and get different results. So for example, someone may show up at a pharmacy and ask for syringes and they appear maybe disheveled or maybe they appear in house and other considerations, and they would get a completely different response like, no, we can't give it to you because you need to be a diabetic or you need to have be on B12 or whatever the case may be. And so no, we won't be able to get it to you. But then you bring someone else in who appears differently, perhaps better groomed, and they will get multiple syringes from that same pharmacist, from that same organization. So I think really kind of showing, and again, that's a tactic of really kind of making staff aware of the fact that we all have these implicit biases, and this is how this is played out in care, where different people will come and receive completely different responses. And these studies, to your question, when I've looked into this, they've controlled by race and age and gender, other things that we may associate also too with discriminatory activity. They control for that, and it really just appears to be, based upon what these studies are finding, that it's really about how a person presents. And going back to the example that I gave of the individual who hailed from Starbucks and who came over to the pharmacy setting, people are making these judgments really with no basis at all. So I think it's really hard to kind of truly assess that what I just described from I guess on a larger scale, and even to what you're asking about some of the best practices. But I think it's really just helping, it's really destigmatizing the conversation altogether, right? And helping pharmacy staff to understand that, as you stated, when you ask your question about people coming in to use substances, well, we really don't necessarily know that, right? We make those assumptions based upon how people appear and how people present, but sometimes we may not know. Now we may have a reasonable suspicion, but all the time we don't necessarily know that. So I think just kind of having an open conversation around the biases that we all possess and what we can do to mitigate those.
So, well, Dr. McCants is asking you to brag on yourself for a little bit and talk about the R01 you just received. How can we help? And then what's the number one thing we can all do today to become harm reduction champions?
Okay, wonderful. So thank you, Dr. McGants. And so I can't necessarily brag on me uh, by myself. I mean, it's a huge team, and definitely kudos to the team at Duke University. I've been fortunate to work alongside them for a while now. I would say pre-pandemic days is kind of how we measure certain things, I'm really excited about the grant to work with alongside Duke University and to work uh, with their partnership in how we're actually looking to assess pharmacy curricula. So we have selected pharmacy schools throughout the country where we're looking to obviously gauge how much HIV pharmacy education is being done in the different pharmacy schools, and what can we do to maybe infuse a bit more HIV education there. What can we do to perhaps increase the interest in HIV related careers? So really looking at these schools and working with them and leveraging their expertise in their pharmacy curricula to really kind of help us with kind of maybe streamlining or really creating a bit more exposure to HIV career paths and epidemiology, things that may not be as highlighted in every school. So thank you so much, Dr. McCants, for mentioning that. So I'm definitely excited about that opportunity. It's been a fun journey working alongside my colleagues here at Duke, and I'm continuing that excitement down the road. And what everyone can do as far as being harm reduction champions, I think some of it is just really kind of owning our own bias and really doing the best we can to situate our bias first and really try to do what we can to really help people in a way where that, it's in their best interest, right? So what can we do? How do we, move aside whatever bias we may have, or why people are using substances, or shouldn't they just stop, or why not this, or why not that, and really kind of look at it from our role as healthcare providers is what can we do to help this person to navigate this journey, because sometimes people are interested in stopping, right? And they are interested in that support to help to stop, but they'll never really get there if they're confronted with people who are constantly wagging their finger at them, or doing other things, as if the person who's wagging their finger doesn't have things that they're working through in their own lives. So I think it's important to make sure that we don't just look at someone as where they are, but really kind of see their potential and where they can go. So uh, that's kind of my philosophy. And again, I know it's going to be different for each person, but just kind of just starting with that humility of we just want to do the best we can to service the needs of others. But again, I want to thank everyone for being here. I appreciate the invitation and be able to come again on such a day as this to share work that I've been doing for quite a while now. So I'm really fortunate to be here and spend this time with you all. And I recognize that World AIDS Day is filled with events. So I'm flattered that you would take time on such a day to hang out with me. So thank you for having me.